Good morning, everybody. I would like to welcome you on our Tuesday's resident lecture. Today on the topic pancreatitis, is there any place for surgical therapy or when would the patient benefit for surgery? The topic will be presented from our sixth-year resident, Richard D'Souza, who joined us 1 year ago. Please.
Thank you, Chris, for your introduction. I also welcome you all here, dear colleagues, and also the auditory at home. I'm pleased to present you today's talk about pancreatitis. As Chris said, the question is, when are we surgeons in duty and when are we needed? So this is the agenda, a brief summary. You will see it's not really complicated. I kept it really slim. We go through the indications to the conservative and supportive therapy and then to the interventional and surgical therapy. We start with acute pancreatitis and followed by chronic pancreatitis. So first main message, in acute pancreatitis, surgery is not indicated unless you have a biliary pancreatitis without cholangitis, without local complications, and without prolonged biliary obstruction. This is on the one hand. On the other hand, you have local complications with no manageable superinfection, for example, a clinical deterioration from the patient, or persistent symptoms like, for example, pain or gastric outlet obstruction. We know from etiology that up to 60% are due to biliary pancreatitis, followed by alcohol, up to 40%, and then there are many various other reasons. About 10% is idiopathic. So if you have a biliary pancreatitis, you should perform cholecystectomy. And when? Well, first you have to check if there are signs of biliary obstruction. For example, elevated bilirubin, or in the ultrasonography, you see a choledocholithiasis with a broadened common bile duct, or maybe just indirect signal of cholecystolithiasis without any obstruction. Well, for being able to take any decision, it is mandatory that every patient with acute pancreatitis has an ultrasonography. Also, we suggest that when you perform a cholecystectomy, you should do an intraoperative cholangiography to really check if there is a choledocholithiasis or not, and maybe to be able to wash out the stone or to indicate a postoperative ERCP. Now, let's follow this flow chart here, how you should decide. Well, you have a biliary pancreatitis and then you check if there is a biliary obstruction. Let's say it is there. You have to check is cholangitis around. If it is, you have to perform an emergent ERCP with a sphincterotomy, and then you follow the non-obstructed algorithm on the right side. If you have a biliary obstruction but no cholangitis, you have to wait 1 or 2 days. If the patient has a mild clinic, you just wait. Does it resolve by itself or not? If it does resolve, it most probably was a stone that went off, so you can follow on the right-hand side the non-obstructed pathway. But if it's persistent as well in the first place, you have to perform an ERCP with sphincterotomy. If at the moment you're looking, there is no biliary obstruction, you have to decide, is it a mild pancreatitis or is it a severe pancreatitis, for example, with peripancreatic fluid? Is it a severe pancreatitis? Well, then wait, don't operate at the moment, and check after 6 weeks if the patient is up to operation. If he's high risk, don't perform operation, do an ERCP and sphincterotomy, and otherwise perform an elective cholecystectomy. Now, the most important part is now if you always can choose on the right-hand side the no. No biliary obstruction at the moment that you're doing the analysis, and just a mild pancreatitis. Then you should perform a cholecystectomy at index admission. We know that, for example, from this Poncho trial 2015 in Lancet, where in a randomized controlled trial they compared early cholecystectomy on day 3 versus interval cholecystectomy 3 or 4 weeks after admission. And they showed that if you perform early cholecystectomy, you have a reduced rate of recurrent gallstone-related complications on an equally low, that's important, overall complication. So it is recommended to do so. Now, I have a question for the audience, for the residents. Can anybody tell me what, for example, a local complication of acute pancreatitis is?
So, for example, an interstitial pancreatitis is a complication in itself, and then there could be an acute peripancreatic fluid collection or, for example, a pseudocyst.
Yes, that's exactly how it is. We have morphologically, since the revised Atlanta criteria classification from 2012, we have interstitial pancreatitis, that's just the morphology, and the necrotizing pancreatitis. And here you see you can have acute pancreatic fluid collection or pseudocyst in the interstitial pancreatitis. In the necrotizing pancreatitis, you can have acute necrotic collection followed by a wall of necrosis. Important here, what's the value of a CT scan? You should never perform a CT scan on acute pancreatitis when patient shows up in emergency room unless you want to rule out something else, like small bowel ischemia or, for example, hollow viscous perforation. Otherwise, you wait 3 to 4 days. That's the time it needs that you can see a local complication at least. So let's go quickly through those. Acute peripancreatic fluid collection. You should not intervene. It usually resolves spontaneously, and it can develop into pseudocyst, then you have to act, but usually it resolves. When it becomes a pseudocyst, you also can wait, because in 50% after 12 weeks it resolves by itself. So you don't need any primary intervention. Secondary, yes, after 6 to 12 weeks, if the patient is still symptomatic. For example, as you see in the picture, the pseudocyst compresses the stomach. Maybe you have a gastric outlet obstruction. If it's super infected or infected, we will come to this topic further on. Or, for example, if you have a special form of pseudocyst where there is a disconnected duct syndrome. Therapy is variable. You can have a percutaneous or endoscopic drainage, surgical drainage. You can go further on until open necrosectomy, for example, if this happens. But you will see in a minute how we decide for the next steps. If you have acute necrotic collection, you also do not intervene at the beginning because it has no definable wall. So any manipulation could spread the problem from a local problem to a diffuse problem. So you just wait. It can then, most often, become a walled-off necrosis. Also in this case, you don't do a primary intervention. You hold on, and you do just in a secondary step after 6 to 12 weeks when patient fully recovered, approach this via step-up approach. This will be a topic followed right now. Step-up approach, we know endoscopic pathway and a surgical pathway, and the end of it, the last step, would be an open necrosectomy. So you see also in this case, surgery not at the first instant. Now here we have a flow chart where also it helps us to decide how we should react when there is a local complication. We will focus on the left side and I will explain why. So if you have a suspected or confirmed pancreatic necrosis, they don't write it, but it's important, it needs to be infected. Otherwise, you just try antibiotics. You don't go for surgery unless you tried antibiotics. And then you have to decide, or you have to check, is there a clinical deterioration or decline? If so, then you can say, we perform a life-saving intervention, an open necrosectomy. We don't have much to lose. But if not, if the patient is stable, you have to go on, ask yourself further questions. For example, is this superinfection persistent? So antibiotic therapy doesn't resolve the problem. If this is the case, you do the first step of the step-up approach. You place drainage. So here, the CT-guided or transluminal endoscopic, and then you go on and check, is there a decline, a clinical decline? If there is one, you again perform a life-saving intervention. If not, you check again if there are persisting system of infection. So the drainage is not enough, and then you do the second step, step up 2, you do a necrosectomy. Here not as specifically written, but just laparoscopic, but again, laparoscopic or retroperitoneoscopic, respectively transluminal. So this is how we decide. Just quickly on the other side, because it's similar, it's just if you don't have any necrosis, you check if there are any symptoms or if the patient fails to thrive. Sometimes we don't know why. And if the patient fails to thrive or he has persistent symptoms, you check as well if there is an infection or not, and then you take the same pathway until you decide how to therapy. We know the conservative and supportive therapy. I just go really quickly. Acute pancreatitis, fluid resuscitation. You start aggressive, but you have to be careful not to run into a cardiopulmonary decompensation. Then symptomatic with antiemetics or with analgesics, you can go up to a PCA pump. And then also nutrition, a very important topic. It is known that all patients profit from nutrition, if possible, enterally. Solid, low fat is safe and tolerant, and you should start in the first 24 hours. Also important to know is a nasogastric tube is equally good as a nasojejunal tube. First, people thought if you don't bypass the duodenum, you have like a constant activation of the pancreas, so the pancreatitis would persist even more, but it's proven not to be any difference. So you can also, if the patient tolerates, just put a nasogastric tube. Enteral feeding is always better than total parenteral feeding, so it is the last option. As you see, total parenteral feeding has a high risk of central line infections or sepsis rate, etc., or also metabolic complications like hyperglycemia. So can any resident tell me when antibiotics are indicated?
If we suspect cholangitis or bacterial superinfection.
That's right. So antibiotics important. They have no place in prophylaxis. Not even if there is a severe pancreatitis. It's regardless to the type of it. But you should start if there is a superinfection, proven or believed, or if the patient doesn't thrive, get better, if the clinical situation deteriorates, in case of cholangitis, or of course if there is another systemic infection like urinary tract infection, catheter infection. In our house, we do empirically, we start with imipenem, or if not tolerated, with piperacillin tazobactam. Then this is the multidisciplinary step-up approach. I said before, there is an endoscopic way to start it or surgical. Here you see, first step is placing of a drainage, followed plus minus a lavage. You have here the nasocystic drainage placement endoscopically, or a retroperitoneal percutaneous interventional placement of a drainage here. So the next step then is necrosectomy. If the patient fails to thrive, to get better, and here you put in a SEMS, a self-expanding metal stent, and perform repeated necrosectomy. And the surgical approach would be a video-assisted retroperitoneal debridement. Which way you choose depends on the experience of the multidisciplinary team. Each house has their own ways of doing it. And then as a last step, you have the open necrosectomy. This was performed like 30 years ago on a regular basis, but has a really high mortality if done at any patient. So this is the last step of this step-up approach. And of course, if there is any clinical deterioration, you have to try it. Most common ways to do it is a planned repeated necrosectomy, as we do it, or you can also perform a necrosectomy with a closed post-operative lavage, or a necrosectomy with closed packing. Important is how do you assess the necrosis? There are two ways. First, you can go in the lesser sac, dividing the duodenocolic and gastrocolic ligaments, as you see here. Or second, you can also go through the mesocolon transversum on the left or the right-hand side. Just be careful not to injure the artery or the vein, the middle colic vessels. And then, of course, there is also a real extended necrosectomy if pancreatitis is dropping down on the paracolic gutters, you have to open the whole peritoneum alongside the paracolic gutters. Important, just 2 points, blunt dissection wherever possible. The reason you see on the right-hand side, bleedings are really difficult to manage. And by blunt dissection, you take really only away what is necrotic, and you give the tissue time to tell you exactly where the demarcation line is. We have some evidence for that. This is published in 2010 in the New England Journal of Medicine, where they check the surgical approach versus open necrosectomy, and of course they could show that the step-up approach is superior to open necrosectomy overall. That's why it's nowadays in the guidelines. And the second interesting point we want to mark out is endoscopic step-up approach better than surgical, and it isn't. It was published 2017 in The Lancet. There is, in the major complication in death category, no significant difference. The first take-home message, the first two, is for acute pancreatitis. So early cholecystectomy during index admission, you should perform it for mild and uncomplicated biliary pancreatitis, and you should follow the step-up approach in treatment of local complications in acute pancreatitis. Thank you for your attention.
Thank you very much. This is always a challenge to speak about acute pancreatitis because that has different opinion, different expertise, and you did very well and cover this topic. We see a number of acute pancreatitis in Switzerland, both from biliary or alcohol, of course, acute pancreatitis. The first point, I just want to make a few points. When you say when, you started by saying, I will talk about when the surgeon is needed. I mean, for this school, this is a surgical disease. And I'm not saying the gastroenterologists cannot, but in many centers, when there is major interest in HPB surgery, all pancreatitis go to surgery, whether you operate or not, because the main challenge is the timing of surgery. So in fact, the best way to treat them is not surgeon or gastroenterologist. We have a unit where they are both active. I think when surgeons are not involved in many centers, this is a problem because they are very often called too late. And so they come in a situation because the main message, do not operate anymore. For 25 years ago, it was you do surgery very early on. That has completely shifted. So I think this is extremely important that surgeons are involved for the first day. Where the patient is located is very not so important. But this is a surgical disease. You mentioned percutaneous. I just go percutaneous pseudocyst. This is prohibited. I think this is wrong. I don't know when this data. We should never, unless there is a sepsis or something, do drainage of a pseudocyst because it will come back, it creates complications. Now, it takes a lot of time. It depends on, again, the local expertise from the surgeon, the gastroenterologist, etc. In my experience, with the surgical bias, this internal drainage are often a problem. I mean, there may be some indication when the collection is on the stomach, but very often with multi-stents, etc., this is pretty difficult for the patient with a necrosectomy, with an endoscopy all the time. Personally, I think this is not a way to go unless I mean, only very few education. Now, to tell that we have this discussion many times for nutrition, everybody agreed today that early enteral nutrition is good. That was not the case. I think that's not on the table. The way of doing the enteral nutrition is different. It was many years ago for surgery. They did the jejunostomy. There was different operation to start. So it's not new, this concept. I think putting the stomach, whatever data is, I think this is not correct. If the patient doesn't go very well, he can bronchoaspirate, etc. So, I mean, in this school, we try to place post-trites for different reasons. There is also a physiology study that shows the activation of the pancreas when you're doing the stomach. This is clear. So I don't think the data are suggesting that do nutrition in the stomach, particularly if it's done in small hospital where there is even less experience, is dangerous. So I think it is a rule. It should really be post-trites. Now, the antibiotics is another very important question. We wrote a review article many years ago, which ended up to be published, I believe, in Annals of Surgery. The New England was very close to accept. They did not because of our recommendation about antibiotics. At that time was going on a study from the Netherlands. So for me, it's not totally clear. My understanding, and I don't completely agree, is that now if it's predicted severe, we don't give antibiotics, right? I mean, if you have Ranson or whatever. On the other hand, when there are necrosis, this is still open. Now, there's a study that suggested even if there was necrosis, we don't need to give antibiotics. I am not sure that's the truth. Maybe if there is minimal, don't need. If there is major, our school here is if there is a major necrotizing, so documented by CT, we give antibiotic, whether it's prophylactic or just to catch up infection, I don't know exactly, but we give antibiotic, but not anymore if it's just predicted. Then we're waiting or we document a necrosis. Final point is necrosectomy. The Dutch have been very active. They published this paper that you mentioned, that you do some sort of minimally invasive with, you go laterally, retroperitoneal, which makes sense. This is not adopted everywhere. And the data they are shown in the New England, the randomized trial, has not been reproduced everywhere. And I am not convinced this is the first route in terms of the timing, etc. So there is one study, this is indeed in some guidelines, but I'm suspecting that many centers, including us, operate late. I mean, what you say is all right, you don't operate prophylactically, but when there are reason to do it, sepsis and others, you have to do it. I am not convinced that the approach with laparotomy, which is more invasive, is wrong. Personal bias, there is a level 1 evidence, but the reality is that many centers, I do believe, will go here either laparoscopically or differently, but not with this reperitoneal route, unless the necrosis is really localized mostly in the tail of the pancreas. A very hot topic. I don't know if there is a question or disagreement, because we see a number of these cases, and also this is not only the specialized surgeon. There are many, and I think general surgeons must be able to handle, and they can handle that very well in this, but it's clear when it deteriorates, I think that has to go to the pancreas specialist. If there's any question?
You're right in saying we should not operate. I think there, in acute pancreatitis, it's okay because the surgeon should be involved. I agree with that. But we should just be careful that we don't hurry too much. We should wait until the patient cannot hold it anymore, until we see it's getting tachycardic, septic, and then just start with a step up. We drain first. We go minimal invasive, whatever, and the last thing, in my view, is the open necrosectomy. Most often those patients will be after the necrosectomy on the ICU. They will deteriorate and having multi-organ failure. So I think if we can avoid it, we should avoid it to go openly. But that's the only thing what I would challenge a little bit.
I have one question. You mentioned in the beginning that patients with obstructive jaundice having cholangitis should get an emergency ERCP. What means emergency? How fast should they get the ERCP?
This is an emergency. So, I mean, number one, it's not very frequent to have this cholangitis, and sometimes it's another cause. It's not a pancreatitis, so you have concomitant, I mean, the stone, we create both. If patient come in sepsis, so cholangitis, and cholangitis means elevated bilirubin, sepsis, etc., it need to be done without delay. The questions, which is not completely answered, but for the group of Hong Kong, is we have a severe pancreatitis, not even of biliary cause, whether you need to do a sphincterotomy or not. And there's been some suggestion you should do it in patient who deteriorates. And when patient deteriorate, there are different options. So here the experience of the team is important. The quality of the ICU is the most important factors in this situation. Here we do not do ERCP in non-biliary pancreatitis or in clear that are not, in situations that are not clear, but we do not.
I have just a brief technical question. I was a bit surprised about the statement regarding early enteral feeding in acute pancreatitis. I'm aware that early enteral feeding is a good thing to do, but you said that nasogastric tube feeding is equally good to nasojejunal tube feeding. And now we know that in these patients there is delayed gastric emptying, there is ileus that can occur. So is that really a good thing to do, to feed these patients with nasogastric tubes, or is that not a risky thing to do?
I make a comment on that at the beginning. I say no. So we do not. I don't agree with that, and in fact we remove it. No, it's not. No, early, of course, it's clear. If patient come in ileus or whatever they have, or perforation, we will not go with that. But most of these patients who come are not really in this situation, and we place a post-trites tube, and then we start slowly with the enteral data. That is pretty solid data that enteral versus parenteral is much better. But again, it's experience of the team, and maybe the most important factor for survival, because survival has to do with the disease, and we intervene, and maybe we do save a few patients, but it's more the naturalist story, because most are very benign, you can do anything, and the other one very serious. The most important factor in survival of this is the quality of the intensive care unit in this situation, taking care of these patients. And the second factor is probably working together. Surgeons should be in the lead of that, or very important in the treatment, and with the gastroenterologist. But there is no role, here, for NG tube here and nutrition in this group of patients, and we have had over the few years some bronchoaspiration, which is the end. The patient was necrotizing pancreatitis, and in addition will bronchoaspirate in the ICU. If the mortality predicted is 40%, it goes to 100% or very close if they bronchoaspirate. Okay? Right, thank you.
Thank you.